Brendan and I want to welcome everyone. We just want to go through these introductory slides, which we're kind of committed to do. Can you go to the next one, Betty? So the program tonight, Louise will introduce. We have 3 cases. The next one. And so for those non-members of the Head and Neck Society, we just wanted to include a link through which you could apply for membership. As you become a member of the Head and Neck Society, you can, if you desire, become a member of the endocrine surgical section and be involved in all of our activities, webinars included. Next slide. And so you are able to obtain CME, and the link for sending the evaluation in and getting the CME will be sent to you by Betty after the program. Next slide. The disclosures for this presentation are outlined here. Next. And so here is the program today. And I'll just jump to the next one because we'd invite you all to our next webinar, which will be in February, which will be non-papillary endocrine histologies, and will involve looking at some more aggressive cancers and also having pathologic input. So we look forward to that program. Can you just go back one now, Betty? And so here is the program. Louise, I'll hand off to you.
Great, thank you. So our first discussant and presenter will be Julia Knoll, who is an assistant professor at Stanford University of Otolaryngology. Our discussant, Amy Chen, at Emory University in Atlanta, Georgia. And I believe Dr. Knoll is going to share her slides, and she'll present the case, and Dr. Chen will break out to have her discuss a little bit, and then we can discuss amongst ourselves. And if you have questions along the way, you can put them in the chat box. We'll be monitoring that, and away we go.
All right, so let me share. All right, everyone can see my screen okay?
Yes, we can.
Perfect. Okay, so thanks everyone for joining us this evening. I'm gonna start us off with a case of papillary thyroid carcinoma with locoregional metastatic disease. And this was a case of mine. It was a 44-year-old woman who was referred for management of what was thought to be an indeterminate thyroid nodule. She had had hypothyroidism and had been managed by a naturopath. Excuse me, this is auto-advancing. Had been managed by a naturopath for the past 12 months on Nature Thyroid. She had no personal or family history of a malignancy and no radiation exposure. So when she initially came to me, she had some vague symptoms, a little bit of globus sensation, some vocal fatigue after speaking for a long time. She did on exam have a palpable right thyroid nodule, as well as a supraclavicular node that felt distinct from the thyroid nodule. On laryngoscopy, she had normal vocal fold motion. And her outside pathology had interpreted the larger thyroid nodule, which was the only one biopsied. Excuse me for the auto advance. I'll try to stop that. The initial outside pathology had been interpreted as suspicious for a follicular neoplasm or a Bethesda 4 classification. And then on the internal review, that was upgraded to a Bethesda 5, being suspicious for papillary thyroid carcinoma. This was the ultrasound report with which she came. We did not have the images available, but there was a report of 2 right thyroid nodules, which were classified both as being TIRADS 4, and night needle biopsy was suggested. And then an adjacent 2 centimeter mass with similar imaging characteristics to the right thyroid nodules. So based on this report, it was not very clear necessarily what the disease status was. And then moving to her in-clinic ultrasound, these are some still photos from her right thyroid lobe showing the the larger of the two nodules on the transverse view, and then both nodules on the sagittal view.
So stopping there, Dr. Chen, sort of like what's going through your head here? And do you have other questions for Dr. Knoll that you'd like to ask her about what she saw?
Okay, thank you. Good evening, everyone. And thank you, Dr. Knoll, for that excellent presentation thus far. I just wanted to make a few comments on things that are really important to do, which you did. One is to get a good HPI, or history of present illness. And if you go back to your slide, Dr. Knoll, if you could go to your very first one, where you talked about past medical history. So I think it's important to ask about symptoms of hypo or hyperthyroidism. Definitely ask about family or personal history of malignancy, and also radiation exposure. Those are all really important questions to ask as part of the HPI. These symptoms, you can go on, that's fine. I know it wants to keep going.
Yeah, I don't know what the auto advance is happening, but hopefully it'll not be too distracting.
The other thing that I just wanted to amplify that she's already discussed is, are these symptoms of, I have a lump in my throat. And many times patients will present to their primary care physician or another physician with, I feel like there's something in my neck. And that's how they end up getting the workup. And that should be her feeling of this foreign body sensation or the globus sensation is likely not related to her thyroid mass, but it is how we came to the story. And obviously we want to be sure to look at her larynx and her vocal fold function, which is why we do a laryngoscopy. So it's very important to do that. I think that if we are to assess vocal fold function by the ultrasound, that's also a good way to look at mobility, but maybe not as good in looking for intra-arytenoid edema, or if there are vocal cord nodules or anything like that. And then the last thing I wanted to comment on her first slides are the requesting the outside slides for review. It's not uncommon that upon review of other slides by another set of eyes, that the diagnosis may be a different one. It may be a totally different cancer, or it could be changed just by the grade, by the Bethesda. So those are some of the comments that I wanted to make sure that we amplify in terms of getting through the HPI and getting to the point where we're examining the patient now. So outside thyroid reports are not really that helpful. The way that I describe it to my patients is that it's kind of like if someone wrote a report about what the Mona Lisa looked like and just told you what it looked like, but you never really saw the Mona Lisa. And if you see the Mona Lisa, it's a totally different view than if you were just to read about it. So that's why we need to repeat the ultrasound in the office. I have to go through that sometimes. It's like, I just had one last week. So we talked about these nodules in the thyroid itself. I think that we have to be, we also have to include the neck. In some institutions, doing a 76536, which is the CPT code for ultrasound, even though it says neck ultrasound, it focuses only on the thyroid. So for example, a report may come in just talking all sorts of stuff about the thyroid, but making no mention of cervical lymph nodes. That doesn't mean that there are no cervical lymph nodes that are enlarged. It may mean that they just didn't look. And that's not part of their review when they do a ultrasound. So I think Dr. Noel is going to tell us about the neck in her next slide.
Yes. So here is a cine clip of her right neck.
So there's that.
And I'm happy to play that again so we can.
Yeah, if you could pause at that cystic mass. That way people can see it. I can't control the pointer, I don't think.
Yeah, I think I can pause down at some of these more macroscopic nodes down here. Well, let me do it. Sorry, having some technical challenges.
So right there, oop. So we can point out the carotid artery.
Sorry, guys.
Okay.
Let's try to. Okay, so carotid artery here.
The vein is compressed right now.
Mm-hmm.
And then there's that cystic mass just lateral to the vein. You know that's a lymph node because we're on the lateral aspect of the great vessels. That other big conglomerate of calcifications is actually the thyroid.
Mm-hmm.
So this is not going to be a Bethesda 4. This is going to be a malignancy based on the fact that these lymph nodes look very similar to what the thyroid looks like. And so if I were to needle something, would I needle the thyroid or would I needle the lymph node? I think I would rather needle the lymph node. I mean, we already know the thyroid was needled, but if I had to choose between, if I could only choose to do a needle biopsy of either the thyroid or the lymph node, I think the lymph node would really satisfy the process of, okay, we're going to biopsy the lymph node. That way we know that it's metastatic papillary thyroid cancer, and you don't have to needle the thyroid to prove that it's thyroid cancer.
So Julia,
I'm just going to stop sharing for a second to see if I can
Okay.
yeah.
fix this auto advance.
So,
Sorry,
and
everyone.
maybe, Julia, while you're doing that, I'll ask Amy, you know, one thing that I noticed is interesting about this person is that they had been getting care from a naturopath along the way. And I wonder, are there any special things that you think about in counseling people who maybe have sort of an unexpected finding when they come to you as compared to what their sort of sense of where they were in their thyroid disorder from their outside facility, and then they come to you and it turns out they have all this metastatic disease. Thoughts about how you handle those in terms of counseling and explaining things?
I think that usually for a new patient, it's actually easier to explain that process. It's more of the ones that had surgery and then they come back with a lymph node and they're like, how did this lymph node come back so fast? I just had surgery 2 months ago and now I already have spread to my lymph nodes. I think those conversations can be tricky. And the way I usually approach that is, you know, sometimes these may not have been seen first time around. It doesn't mean that it came back so quickly. It may just mean it was just not seen at that time, and now we have to take care of it. So just because we have a lymph node now and you didn't have it 2 months ago, doesn't necessarily mean it wasn't there 2 months ago.
Yeah.
And so
really good. That's a really good insight. Dr. Knoll, you had a nice picture of the pathology. Do you want to walk people through that? That was a beautiful picture of the surgical specimen.
Oh, but let me just talk about the TG wash.
Oh yeah.
So sometimes I think you can do a thyroglobulin wash, which just means that when you aspirate the lymph node, in addition to sending it to cytology, you can send a little bit to the chemistry lab for them to check if there's any thyroglobulin in that needle. Now, for some, I think for some individuals, they feel like if the thyroid's intact, that this is not as good a test. But I think that if it's this high, it's not just going to be from the blood, from Dr. Knoll causing the patient to bleed and having some blood in the needle, and therefore the patient already has a thyroid, so then that's where the thyroglobulin source is from. So I agree with getting a thyroglobulin wash, particularly in tricky lymph nodes that you may not get good cytology on. So anyway, just wanted to talk on that.
Good. Julia, I'm just going to have you quickly show us your surgical pathology, and we have just about 2 more minutes or so to talk about what happened with this case.
Sure. So she ultimately had a total thyroidectomy, bilateral central neck dissections, and a right lateral neck dissection. So the photo sort of gives a breakdown of the nodal levels, and then this is a condensed version of her pathology, on which she did have angioinvasion, but fortunately not other adverse features, and had 13 of 68 positive nodes.
That's great. So, and closing thoughts that you had. I think I saw another slide that you had go by.
Yes, this was my reference that I picked out, which I just think is kind of a nice summary of where the disconnect occurs sometimes between radiologists who might be obtaining and or interpreting thyroid ultrasounds, and surgeons who are heavily reliant on those images and interpretations to plan a surgery, and how the image acquisition and reporting does not always translate to what's relevant to a surgeon in their planning. So this particular paper just advocated for increased standardization in image acquisition and how things are reported, so that there's consistency between the radiology and surgical language.
Yeah, I think those drawings and especially can be particularly helpful. So somebody's asking about why you didn't include 2B in your lymph node dissection, which is a good question.
Yeah, and I did. I'm glad someone asked, because the top of the picture was a little cut off, but I did send a lymph node from level 2B as a frozen, and based on that lymph node being negative, didn't do a more complete 2B dissection.
Yeah. That was a really excellent presentation. I'm just going to actually let us move on to our next case, just in the interest of time. We can always come back to this one. This one has so many good things to discuss. Our next case is going to be presented by Dr. Alice Tang, who is an assistant professor at the University of Cincinnati. And our discussant is Dr. Marika Russell. Dr. Tang, why don't you go ahead?
Hi, thank you for...
Oh, we can barely hear you. Make sure you're speaking right into your...
How about that? Is that a little better?
Tiny bit better.
A little. It was working earlier.
Yeah, it's still quite muffled.
Okay.
Alice.
Is that any better?
There you go. That's a little better.
A little better? Okay.
You might have to talk really loud.
I'm used to talking loud. This is good. I'll be comfortable doing it. I just can't get my... Can you see my screen?
Yep.
The screen is good, just the sound is a little low. Can you get closer maybe? Yeah,
How about that? That's good?
Yeah.
Okay.
that's really good.
Better.
You should get headphones.
I do. They're somewhere with the kids. I have a case on medullary thyroid cancer. I'd like to thank Greg and Brendan for putting this together. This is super fun and a great learning experience for myself as well. This is a case about medullary thyroid cancer. Is a patient that I took care of when I first started practicing. So I thought it was a great learning case for me, and hopefully it'll be for everyone else as well. So this is a 63-year-old gentleman who incidentally found to have a thyroid nodule when he obtained a CT scan with contrast of his neck for other reasons. He was essentially asymptomatic, no dysphagia, pressure, didn't really know that it was even there until somebody told him. He himself has no family history of thyroid cancer or thyroid disease, and he never underwent any type of head and neck irradiation. He was clinically and biochemically euthyroid. His only past medical history is type 2 diabetes, and he's a non-smoker and non-drinker. So he underwent a standard of care for a thyroid nodule, which included and started with a thyroid ultrasound. And that demonstrated a single dominant left-sided thyroid nodule that was solid, heterogeneous, had coarse calcifications, irregular borders with a maximum size of 2.3 centimeters. When I performed the ultrasound in the office, there was no central or lateral cervical adenopathy, consistent with what the CT scan had shown that was obtained for other reasons. So following the ultrasound, he underwent a fine needle aspiration, which returned as Bethesda 3. This was then sent for molecular testing, and that came back as suspicious with malignancy classifier positive for medullary thyroid cancer. Preoperative workup for medullary thyroid cancer at this point, given that the classifier told me that it was medullary thyroid cancer, included things that I normally get on patients, which would basically be vitamin D and calcium if I thought that, and a PTH if I thought that I would be performing a total thyroidectomy. In this case, we also want to think about familial medullary thyroid carcinoma, other secretory tumors, including a pheochromocytoma. So here I obtained serum catecholamines that were fortunately all within normal limits. So with medullary thyroid cancer, because the parafollicular C cells undergo hyperplasia, which then turns into medullary thyroid cancer, calcitonin and CEA are useful tumor markers that I can obtain to measure tumor volume and to confirm that this indeed might be a medullary thyroid cancer. RET mutational testing, I don't do that before surgery usually. I do it post-operatively, essentially to guide genetic testing as well as, genetic counseling for his first-degree family members.
That's great. So, Dr. Russell, what are sort of the highlights that you notice in this workup?
Sure. So I think one of the things that you nicely highlighted is the fact that medullary thyroid carcinoma sometimes presents a diagnostic challenge in terms of the cytologic diagnosis being known right up front. And so you can often see this as presenting as an indeterminate nodule, not unlike the first case that we saw with a Bethesda category 3 or 4 or 5. And so, fortunately, when you have molecular testing available, both Afirma and ThyroSeq are very good at detecting medullary thyroid carcinoma. But I think it's worth noting that in some clinical environments, molecular testing may not be available. And so one thing that you can do in that setting is obtain a serum calcitonin. And that may give you a clue as to whether or not you're looking at a medullary thyroid carcinoma. It's easy to do, and we don't advocate for screening of all patients with nodules, but it may be a worthwhile consideration in a patient with an indeterminate nodule. And so, as you suggested, you completed the workup that you would obtain for a patient in which you would want to rule out a familial medullary thyroid carcinoma, so MEN2A or B, or familial MTC. And you've also obtained your parathyroid hormone to rule out the presence of a parathyroid adenoma. Your calcitonin is elevated as you would expect, and the CEA also mildly elevated as well. So I think you've done a complete workup for this patient. As you suggested, the germline mutational testing will need to be done, and that can be done, oftentimes it is done after surgery because there's sort of a delay in patients getting to genetic counseling for that. So the next steps, you're going to prepare for your surgery, and you indicated you found on your ultrasound that there were no clinically evident lymph nodes either in the central compartment or in the lateral compartment. And so then even in the absence of central neck disease with medullary thyroid carcinoma, unlike With differentiated thyroid carcinoma, you have to make the determination about how to handle the nodal compartments, specifically the central neck. Even in the absence of clinical nodal disease, you're going to want to dissect that central compartment. And so discussion of the lateral neck is a little bit more complex. And I know there's quite a bit of controversy over whether or not to address the lateral neck. We'll see what you did. I think an interesting, just moving back to this sort of diagnostic dilemma, an interesting question may come up for folks who don't have access to molecular analysis. What happens in the setting of an indeterminate nodule where you perform a diagnostic lobectomy and then you discover that it's medullary thyroid carcinoma. And then the question becomes, do you need to go back and do that completion and central neck? And I would be interested to hear maybe some of the other panel members on that. But that, the standard operation would be to go back and do the completion and the central neck, but in the setting of perhaps a patient who doesn't have a germline RET mutation, that might be something you would watch. So I think we're ready to move on to what you did.
There's a good question there. In the chat box, someone was asking about whether imaging or labs are often preferred for this kind of workup. And Dr. Tang, was there any discussion at your institution about whether you should go on to get imaging, or were people happy with labs?
It is, usually it's faster to get labs, and I could get it done the same day, and I could get an indication of whether or not there were other multiple endocrine neoplasia happening.
Yeah.
Imaging, I could have gotten an abdominal imaging, and I would have if I felt that there was bulky regional disease, that then I wanted to look for metastatic disease, which then would encompass some of the imaging that would inform me of other things going on. But generally, I do start with serum labs with catecholamines, and I start there, and I let that guide me with what further workup I would need to do.
Yeah, that's a great response. I know in the chat box, some people said, some endocrinologists seem to prefer imaging over labs, but I think what you described sounds perfectly reasonable also. So let's go on from here and see what happened.
So he ended up having a sporadic medullary thyroid cancer, which is more common than the familial. And preoperatively, I staged him as a T2 based on the size on the ultrasound, clinically N0, and I didn't obtain distant metastatic workup, so it would be an MX based on the 8th edition AJCC. So I elected to do a total thyroidectomy with bilateral central neck dissection. I did consider lateral neck based on the calcitonin, but I think that given the absence of disease I saw on imaging, I felt that starting here was a very reasonable approach, and that I would see how I did biochemically afterwards.
And if you were in Japan, you would be in good company. They do not do prophylactic lateral neck dissections for medullary cancer there.
That's great to hear. My pathology results, it ended up being a 1.7 centimeter. So we downgraded his stage to a PT1B based on the size. There were lymph nodes that were positive, 2 out of the 10 out of the central compartment. And I was able to obtain the lab work that I needed post-operatively, and it suggested that you do it at 3 months. But I get too excited afterwards, so I usually check it previous to 3 months. So here's my post-op lab surveillance, and he fortunately had normal calcitonin laboratory values afterwards and CEA that eventually normalized. He was hypothyroid and was slightly hypoparathyroid as well, that resolved within a few weeks. And then I was able to follow him, and he's currently 3 years out he's doing great. But I also do every 6 months, now every year, ultrasound with a basal calcitonin level, as well as a CEA level. If the calcitonin had shown something different and I was concerned, that's where that kind of additional workup would have been triggered, and to really look for if I had missed disease, if there was other disease, or if I would have had to go back to do the lateral neck. And my last slide is this paper, which I really felt was informative in why we follow calcitonin doubling time. And this was a French study that looked at 5 and 10-year survival rate. It was actually through 30 years, and found that if the calcitonin level did double less than 6 months, their 5-year survival was 25%, and then their 10-year survival was actually 8%. So going back to the patient, now that we're about 3 years out and his calcitonin actually was pretty stable, all the patients in this study were alive at the end of their study period. So it's a great prognosis for him. And it's the only independent variable that we can really count on to be pretty specific for survival rate.
That's really excellent. Thank you. Dr. Russell, we have about 2 more minutes. Closing thoughts from you on this case.
Sure. Well, I think you did a very nice job, as you saw from your calcitonin coming down into the undetectable range there, that you've cleared your disease biochemically. And so the choice not to do a lateral neck dissection was probably the right choice for this patient, a la how they do in Japan. And as you suggested, this patient is going to do probably very well. Those patients that have a return of their calcitonin to a normal level after their initial surgery are those that have the most favorable prognosis. So you really want to be able to get out your disease the first time around if you can. And you've watched him now over a 3-year period, and he's had very stable calcitonin levels. So I think he has a fairly good prognosis looking forward. Good job.
Just as a last question, one question that came up, Dr. Tang and Russell, was whether people have a preference for calcitonin versus CEA with regard to surveilling or staging disease. I mean, you nicely outlined why to use calcitonin, but any role you think for CEA, or do you not bother?
So if CEA is elevated and calcitonin actually goes down, it's actually indicative of a poorly differentiated medullary diet.
Right.
There is a role, but furthermore, there are other things that to the person who asked the question, to his point or her point, there are other things that produce CEA. So you would think of colon cancer, and that's why calcitonin is generally more preferred, but I do like both. It makes me feel warm and fuzzy. And I know what to do if CEA is weird and calcitonin goes down. So,
and if you have evidence that there may be some structural disease that's persisting or recurrent, but your calcitonin is not doubling or not rising, then your CEA may serve as a marker to indicate that the disease has dedifferentiated, as Dr. Tang suggested. And you may not see the calcitonin rise, and maybe the CEA that's on the rise. So there is a role for measuring that when you have a concern for persistent or recurrent disease, despite there being a rise in calcitonin.
Well, that's great. That's excellent. I'm going to move us on to our last case so that we'll have time at the end. Thank you, Dr. Tang and Dr. Russell. Let's move on to Dr. Shanka, who will be presenting a parathyroid case, so moving us into a slightly different realm. Dr. Shanka is at the University of Virginia, and Dr. Wong will be the discussant. He's at Memorial Sloan Kettering. Take it away.
All right, can you see my screen okay?
Absolutely.
All right, so yeah, switching gears a little bit. So this is a patient, 65-year-old man who came in to see me, and the referral note said for parathyroid cancer. And this was in August of 2019. So when I met him in August of 2019, he had undergone a parathyroidectomy on March 11th, 2019 at an outside hospital. And at that time, he reported symptoms that had developed in December of 2018, including fatigue and anorexia, with some weight loss, some memory impairment. He had become unable to perform some of his ADLs. And then his symptoms resolved after the surgery in March, and he did have some mild hungry bone syndrome. At the time I saw him in August, he felt great, no voice or swallowing problems, and he had no history of radiation exposure or family history of thyroid cancer or parathyroid malignancies. He does have several other medical problems, including early dementia of traumatic brain injury in the past, stroke, cardiomyopathy, and others. So at the time I saw him, he had a well-healed midline transverse scar, no palpable neck mass. He had normal vocal fold mobility on flexible laryngoscopy. Other than the scar, this was the same as his exam prior to his initial surgery at the outside hospital. These are his labs prior to his initial surgery. He had a calcium of 11.2. His ionized calcium was also elevated. His PTH was 111.6. He had an ultrasound prior to his surgery at the outside hospital, which showed a 2.4 in largest dimension centimeter hypoechoic lesion near the inferior left lobe of the thyroid. And he also had a SPECT CT that suggested a parathyroid adenoma in the same location as the ultrasound. And here is the ultrasound image.
Do you want to just point out for the group where what you're looking at?
Yeah, so this is a transverse image. Here's the left thyroid lobe. You can see a bit of the carotid artery here. And then this is the parathyroid candidate lesion here, this hypoechoic lesion.
Yeah, and that looks sort of irregular, doesn't it?
Yeah, it does to my eye.
It does to my eye as well. Dr. Wong, thoughts from you at this point?
Yeah, so this is a really interesting case. Parathyroid, atypical parathyroids and parathyroid cancers are both quite rare, and there probably is a spectrum of normal parathyroid adenoma with parathyroid neoplasia to atypical parathyroid to parathyroid cancers. You might see a couple in your career. They're very rare. And usually they present in a very dramatic fashion. The cancers usually present with extremely high serum calcium levels, and patients can be extremely symptomatic. This doesn't happen so often because most people get blood tests with their primary care providers, and if their calciums are rising up, it's usually detected before it gets to 14 or 15. But the classic presentation of parathyroid cancer would be with very high calcium levels, severe bone disease, severe osteoporosis, fractures, kidney stones, the whole thing, like the whole bones, moans, groans, all that stuff you learned in medical school. That's the typical presentation. I think it's really interesting. One thing that's interesting pathologically, and we'll get to that when we look at the pathology, is that there are some genetic markers for parathyroid cancers that could be helpful in making the diagnosis, because the spectrum is so confusing. And even looking under the microscope, it can be difficult to figure out what's a cancer and what's atypical. I think your point about the ultrasound borders is very important. Sometimes the diagnosis of cancer has to be made based on clinical grounds. If you're not sure if you can see an invasive front, obviously if there's a metastasis or a clearly invasive border, lymphatic invasion, capsular invasion. And I think that often these are, the initial presentation of these is often as a parathyroid adenoma. And I think often what happens is the surgeon goes in expecting it to be an adenoma, and the classic description is that they find that it's sticky and adherent. And of course, adenomas usually separate really easily and nicely. So already there's a problem there. And then there's the whole discussion of what do you do then? Do you just take it out and scrape it off and peel it off, or do you escalate and do a lobectomy, or do you do more? And these are questions I'm going to ask the panel a little bit later. But I'll let David continue with this interesting case.
All right, so at this point I reviewed the outside operative note, and it was a pretty sparse note, but it basically said that a left inferior parathyroidectomy was performed, recurrent laryngeal nerve was identified and preserved. They noted some adherence to the surrounding fascia, and had actually sent a frozen section of the parathyroid that the pathologist had called suspicious appearing at the time. But they didn't remove any lymph nodes, nor was the thyroid lobe removed. They did say that there was a greater than 50% drop in the intraoperative parathyroid hormone level. The outside path report, again, there was the frozen section and then the permanent section, but they thought that there was vascular invasion, which is why they called this a parathyroid carcinoma. They said capsular invasion couldn't be completely ruled out because a frozen section had been taken, and so part of the capsule was missing. So at the point that I saw this patient 5 months later, the parathyroid hormone level was normal at 30.4, calcium was normal at 9.5, and I set the patient up for a CT scan a month later, so that would be at the 6-month mark after surgery. And this was read by our radiologist as showing some post-surgical changes from the parathyroidectomy, but no enlarged lymph nodes and no evidence of residual tissue or tumor in the operative bed. I also had our pathologist review the outside specimen during that time. And I have to thank Kristen Atkins, one of our fabulous head and neck pathologists, for these great pictures. So these show different types of parathyroid pathology. And so you can see along this top row, this is at 40x magnification, and here at 200x. This is what a normal parathyroid looks like. You can see all of the fat in that normal parathyroid. And in fact, the entire gland can be visualized on this one slide image at 40x magnification. And you can see that again at the 200x, the different types of cells, with some of the pink or lavender colored cells being chief cells or oxphil cells. Then here's an adenoma. So you notice that the fat is gone and there's more dense cellularity in that. And then this is the current case. So you see some of the parathyroid cells here, but then in between the parathyroid cells is these sort of fibrous bands that would indicate some type of host response to the pathology. But what's interesting is if you look at these two, the adenoma and the atypical parathyroid, so now we're at 200x looking at one of these purple areas on the parathyroid atypia versus the parathyroid adenoma, they look awfully similar. So if you were to just show a pathologist this and an adenoma at 200x, they would think they look awfully similar. This is just looking at the border difference. So here's a parathyroid adenoma that has a nice smooth border on the pathology, whereas this particular patient, you can see the border is more lobulated. But again, you can see sort of at least in the parts that were visualized, an intact capsule around it despite the lobulations. So, you know, the big challenge with parathyroid cancer versus benign parathyroid findings is almost similar to the differential between a follicular adenoma and a follicular carcinoma. You're really looking for invasion, and whether that's invasion of the capsule or the surrounding structures for a parathyroid adenoma or vascular invasion. If you see those things, then that helps the pathologist call it a parathyroid carcinoma, but there aren't really any histologic slam dunks like increased mitotic figures or nuclear atypia that would separate a atypical parathyroid process or a parathyroid carcinoma from a parathyroid adenoma. And so I think that's the point.
Yeah.
And unfortunately, they did not see in this patient any evidence of vascular invasion that they could hang a hat on or surrounding tissue invasion.
Yeah. So Dr. Wong, I have to say, as you said, this is an incredibly rare kind of thing. I personally have had one that I've seen in my career, probably in New York City. You see more of them. What post-operative management might people consider as options here?
Yeah, it's a great question. I guess the first thing is I would ask the pathologist to study for that focus of vascular invasion that they saw at the outside hospital and see if they agree or disagree, because that would be criteria for calling it an invasive cancer. but I wouldn't be surprised if they didn't see it. That's probably why they didn't call it a UVA. Other things you can do is you can test for this gene that codes for parafibromin. It's the HRPT2 gene. In a quarter of patients that have cancers, they'll have a germline mutation, in which case you should do genetic testing for the family. And in probably about 75% of patients, that gene is mutated, the other 50% being sporadically acquired. So that gene does track with the real cancers. But again, presentation is usually more aggressive with higher calciums. So those are things you can help with the diagnosis.
Yeah.
In this particular case, after the case is done, I think what David did was very appropriate. He carefully imaged the patient, and he's going to track the calcitonin level and the calcium levels. And interestingly, when people get into trouble from these cancers and they recur, the way that they get into trouble is not so much local invasion like an anaplastic thyroid cancer, but they typically die from uncontrolled hypercalcemia and recurrent disease that is functionally overproducing parathyroid hormone. So that's kind of a way you can sort of measure how you're doing systemically. But I know that the story here goes on, and David, I think in tracking the patient, noted that initial PTH was, I think, in the 30s. On a subsequent later one, it came up, I think it was in the 70s, David? Was that right?
Right.
Yeah. So David, you have about 2 minutes,
Okay.
and maybe just, share with us what happened. That's great.
Yeah, so ultimately we decided, since he looked pretty good at 6 months and because of all of his comorbidities, we opted for close observation with serial imaging. And so now at 1.5 years out from surgery, his calcium is 9.2. And as Rich said, his PTH has gone up a bit at 74. It's still normal. And his calcium is slightly lower than it was when I checked him the first time. And so I don't know if that's just an appropriate change in the PTH with a slight decrease in the calcium, but we plan to continue to watch him and see what happens over time.
Yeah, I might suggest that you continue with the 4D CTs and ultrasound and look for structural disease and track the PTH and calcium. I guess my question to the group is, let's assume that this patient in another year, the PTH becomes then 120, and let's say you see a little bit of enhancing tissue in that left thyroid bed area. At what point do you consider intervening surgically? And then the second question is, what would that surgery look like? And maybe we could ask some of the seniors here who are laying back, like Dr. Greg Randolph and Dr. Brendan Stack. They're not going to get the night off. Greg and Brendan, let's pretend this PTH is rising and you see a little something. When do you interact? When do you act? And then what does the surgery look like? Do you do lobectomy? Do you do central compartment? Or do you just remove whatever recurs? And how aggressive?
I'll let the complicated answer come from Brendan, but I would agree with Maisie Shindo that if this PTH went up just a little bit, this would be more suggestive of a need for a bottle of vitamin D than for aggressive reoperation for recurrent parathyroid cancer. And the other thing is, I think, I know David, and he forensically analyzes the data from prior patients, as he should. And he, interestingly, if you pay attention to his commentary, he noticed that the capsule had been ruptured. So parathormatosis and parathyroid cancer collide in an indistinguishable, chaotic, and unsatisfying way. And that could be the source of a recurrence in the bed, multiple satellite. And then to distinguish that from cancer becomes ridiculously hard because you have a focus of adenomatous, atypical adenoma growing within muscle. No pathologist worth their bootstraps are going to call it non-malignant. So you really can't sort things out there. So I would say to look back and even call the surgeon and say, I know you got a biopsy and maybe the capsule was ruptured. What's up with that? How was the surgery? Was there any question of rupture? And I think that would be something also to talk about. But I'll let Brendan answer the more complicated question of if the PTH and calcium skyrocketed and you had a nodular recurrence in the bed, what would he do?
And
So,
Dr. Stack, I'm going to give you about 1 minute before I cut you off so we can take one good question from the audience. Go ahead.
Absolutely. I would be a hypocrite if I went over after I've been pestering you. So basically, Rich, this is what I would do. I would follow the PTH doubling, and if the PTH was doubling in the area of 6 months or a year, and I would do some repeat imaging. And if the target lesion that I was suspecting was above 1 centimeter, I'd probably go in and do an exploration. And the exploration would probably consist of what I would have done if I knew this was parathyroid cancer a priori, which would be ipsilateral hemithyroidectomy, removal of the parathyroid cancer, and ipsilateral level 6 with intraoperative nerve monitoring.
That's excellent. That's perfect. I'm going to pose a question back to Dr. Knoll. Just in the last remaining moments we have, a really excellent question came up from the group. They wanted to know how you're following your patient after she had her radioactive iodine. This, if you recall, was the person with the metastatic papillary thyroid cancer. She had 13 nodes positive. She had 150 millicuries of radioactive iodine. How often do you see her back? Are you seeing her every 6 months, every year? Are you getting thyroglobulins? What are you doing, and what's your usual pattern?
Yes, she had not seen an endocrinologist prior to seeing me, so that was the first thing we did, was made sure that she was connected with an endocrinologist. I will be seeing her every 6 months just to do in-clinic ultrasound, and she'll also be having thyroglobulin antibody, along with concurrent TSH checked at the same frequency. I think the second part of that question is regarding a threshold value for TG about which to be concerned.
Yes, thank
and
you.
I think that sometimes is the million-dollar question, especially with so many different assays that sometimes change even within your own institution without knowing about it. And I think all the thyroglobulin and antibody just need to be taken into account with the ultrasound findings as well as the trend. And if there's a high level of antibodies, potentially sending that test out to try to better distinguish what is truly, potential disease.
That's an excellent summary. I think following the trends and kind of putting the whole picture together. So we are right up against 9 o'clock. I want to really thank everybody. First of all, Drs. Randolph and Stack, for inviting all of us to be your presenters and discussants tonight, and for the excellent questions that you all asked in the chat box. I'm sorry we couldn't get to all of them, but I know that many people answered them. Any last words from you, Dr. Randolph or Dr. Stack?
Thank you very much for our presenters and all the comments from Amy and Rich and Marika as our discussants. Please tune in for, about next month or so. Betty will be sending out information, and you can get CME with the email that Betty will send. And Louise, thank you especially for your leadership and guidance of all of us.
Thanks all.
Thank you.
Thank you very much.
Thank you.
Bye-bye.
Thank you, everyone.